you very much, John, and I appreciate everyone for inviting me here today. It's quite an honor to speak, especially since I owe my presence in academic medicine to thoracic surgeons and actually my career. So thank you very much, John, and Blair also for being nice to me during the course of my fellowship. We went through many of these difficult cases together. So these are my disclosures that I have, none of which unfortunately are making me rich. So if you have any disclosures that you can add to my list, I'm glad to accept them at the end of my talk. The biggest disclosure was when I looked through the manual for this course, that I saw that I'm supposed to be talking about an evidence-based approach to central airway stenosis. And having reviewed all the literature, I realized that there is almost no evidence-based medicine. It's almost all experiential or anecdotal. And so what I'm going to be giving you over the course of the next 15, 20 minutes, although we're short on time, is really the approach of a pulmonologist trained by thoracic surgeons in managing airway stenosis. So it's my approach. It may not be your approach, and I'd be interested to hear how my approach differs from yours. So the goals of the presentation really are to briefly review the various types of central airways obstruction, to discuss the means of intervention for central airway obstruction, and to establish treatment algorithms, understanding that there are different practice patterns among different types of physicians. So how does a pulmonologist, even a reasonably well-trained pulmonologist, approach someone with airway stenosis? And this is really the only slide that is actually very important to remember, for at least from my perspective. So when I have a patient come in with an airway stenosis, my first question is this an emergent or a non-emergent situation? Does this person need to go to the operating room now, or do I have some time to think about it and pull together some more data? Is this a patient who has a malignant problem, or is this benign? And I say benign in quotation marks because a lot of the benign stenosis that we see are truly malignant in nature in terms of what they can do. They can be life-threatening even if they're non-malignant. What is the anatomy? And again, a chest x-ray doesn't give you a lot in terms of the anatomy, but what is the anatomy of the lesion? How we approach it really depends upon the delineations of the anatomical boundaries of the stenosis. Is this a surgically resectable lesion? This is important for me because I can't do the surgery. So if I'm going to be interceding on this patient, I need to make sure that I'm working together as a team with my surgeons so I know whether this is a patient who's ultimately going to be a patient who's going to have definitive treatment for their disease. Do I have all the team members that I need for this particular case if I'm going to approach it? So if it's an emergent case and I can't oxygen or ventilate the patient, do I need to have a team to put the patient on bypass, which we very rarely do for the case? Do I have to have a surgeon available in case we need to establish an emergency airway? Do I have all the instruments that I need? And in particular, do I have all the types of bronchoscopes that we needed to manage the airway? And this is very important because planning is extremely important. I tell all my fellows that you have to think out the entire procedure in advance before you actually do the procedure. So in terms of managing central airway obstruction, there are so many different varieties of airway obstruction that one can encounter in different anatomical configurations that it's hard to come up with one specific algorithm for a different type of airway stenosis. So, for example, you see a patient with tracheobronchomalacia, in this case, mostly from excessive dynamic airways collapse. The way you're going to manage this airway problem is very different than how you manage a tracheal tumor. One of the things that has changed our approach to managing airway stenosis has been the ability to obtain excellent imaging, especially 3D reconstructional imaging. And in the past, when we had gone to diagnostic bronchoscopy to establish the anatomy in advance of doing the actual procedure, we do that more or less frequently, I should say less frequently now, when we have the ability to get CT scans that delineate, in this case, a tracheal stenosis or a left main stem stenosis, so that we really know in advance what we're dealing with and can plan one procedure for the patient. And again, I wouldn't be a good pulmonologist if I didn't show some pulmonary function tests or flow volume loops. I actually don't really obtain them, but I had to show the obligatory slide. Benign stenosis I wanted to start with because this is a disease that we truly share quite commonly with the surgeons. To preface this is that I try to get these patients as much as possible to definitive resection as I can. So if I can be hands-off as much as possible, that's good. And we get involved primarily when we need to bridge the patient to a definitive procedure or when they're not a candidate for a definitive procedure. So what are the questions that I ask myself when I'm presented with trying to manage a benign central airway obstruction? Well, as a pulmonologist, even an interventional pulmonologist, I have to consider these patients need a future procedure or likely may need a future procedure. So I don't want to do something to the patient that will preclude them from getting a procedure which will be definitive later on. And again, this is part of the same thing, which is that I don't want to interfere with the ultimate surgical plan. I want to, if I'm interceding, to help the surgical plan, to make the patient more stable ultimately for a surgical plan if they're a candidate for surgical resection. If I'm going to do a diagnostic bronchoscopy in advance of the procedure, I don't want that to be a complicated procedure. In other words, I don't want to go into a patient with a very tight tracheal stenosis, put in a flexible bronchoscope, occlude the airway, and cause respiratory distress. If I'm going to take a look, I'll look with a pediatric bronchoscope, not occlude the airway, and get an idea of the lay of the land before we do the procedure. And lastly, in these patients with benign disease, whatever I do should have relatively low risk, both short-term and long-term for the patient. In terms of the etiology, we're all familiar with the etiology of upper airway stenosis from congenital, acquired, inflammatory, idiopathic, and anastomotic complications. We typically encounter anastomotic complications primarily in benign bronchial, not tracheal stenoses. And the subglottic region, the data show what we seen at Penn primarily, which is about an even split between post-intubation and idiopathics. And again, the relationship between reflux and subglottic stenosis has never been well established, although it's here in this paper from 2006. We see much more common, this is a slide I got from my friend and colleague Mike Machuzak from the Cleveland Clinic. This is a much more common scenario for us, which is the idiopathic subglottic stenosis. Much more rarely will we see the subglottic Wegener's, which actually is a very difficult diagnosis to make. When we evaluate these patients, we're trying to establish the location of the lesion, the extent, the presence of comorbidities, very careful team-based planning, good communication with the patient, the family, and the rest of the team, thorough pre-op evaluation. And what remains to be not well worked out is the interaction between endoscopic management and surgical intervention. Meaning, when is there a role for endoscopic intervention alone? When is there a role for endoscopic intervention in advance of surgical therapy? Or when should patients just go for surgical therapy? And I think this is where evidence-based medicine can help us out a lot, and yet we really don't have anything in the medical literature. We have, again, anecdotes and experiential reports. But I think that as you approach endoscopic management, going back to my point before, what I try to do if I'm going to manage them endoscopically initially is not do something that's going to impair this down the road. So if I'm using an approach to ablate an endoluminal process, I try to avoid injuring the airway that's going to worsen the capacity for them to undergo a tracheal resection. So in the older medical literature, and this is now 31 years old, these patients who are managed endoscopically typically are able to go through the procedure with less morbidity than surgery, with a shorter hospital stay, yet they require repeated procedures with a lower ultimate success rate. I can get non-surgical patients through endoscopic approaches, and interestingly, age is not a contraindication. So an 85-year-old who might be too sick for surgery, I can still get through an endoscopic approach for their airway stenosis. But if they've got circumferential narrowing, especially narrowing greater than 1 centimeter, they have tracheobronchomalacia, if they have severe airways infection secondary to prior tracheostomy, or they've got scarring going up to the posterior laryngeal inlet, our endoscopic approaches are much less successful. So how do we approach the benign airway stenosis endoscopically? A combination of approaches with anti-inflammatory medication, incision, dilation, and then maintenance therapy with stenting. So anti-inflammatory therapy isn't always used, and there's very little evidence-based medicine showing that it's beneficial. Again, this is primarily by anecdote, but you should treat a systemic disease preoperatively or pre-endoscopically if one is present. You should potentially use injection of steroids, and we use triamcinolone at Penn, but there's no data supporting using one versus another. And then after instrumentation, people use corticosteroids and mitomycin, but again, there's not a lot of good data supporting either one. There is reasonable data suggesting that you can get good outcomes with incision and mucosal sparing techniques prior to doing dilatation. We currently use a papillotome to minimize injury to the normal mucosa, and then do rigid bronchoscopic dilation or balloon dilation or both. Balloon dilation gives you a good radial direction and pressure, theoretically less damaging to tracheal wall and mucosa, good initial results, and may obviate the need for stenting, but balloon dilation typically leaves you with the need for repeated procedures. And if you have a patient who has an autoimmune disease and you do a balloon dilation, you can actually exacerbate the process. The risk of balloon dilation, if it's done especially by the inexperienced proceduralist, is injury to the posterior wall of the trachea, which can be a very serious problem. So in terms of stents, the bottom line is that stents will provide you an adequate airway during the maturation of the stenotic lesion, and particularly in the benign process. It can be used prior to definitive surgical resection in some patients or in lieu of definitive surgical resection in some patients. In airway benign disease, silicone stents should only be used. Removal is possible and relatively straightforward with rigid bronchoscopy. There's less granulation tissue. It allows for remodeling, and there is an FDA black box warning on metal stent use. And these are the variety of stents that are available. This is a polyflex stent, which we don't recommend using in the airway any longer because of a high rate of migration. These are the metal stents that we typically do not use in benign airway disease. We use almost exclusively T-tubes for upper airway lesions, and then the Dumont stents for the tracheal and lower airway lesions. T-tubes, remarkably, after 50 years since their initial introduction, still are tremendously useful, especially for mid-tracheal and subglottic lesions, and we use them very commonly, again, in a multidisciplinary approach. The polyflex stents, as I mentioned, are not really useful for this patient population, and there still is a migration rate which is too high for the Dumont stent. We have to find a better stent for this airway, especially in the subglottic location. And these stents, remember, even though they're better than metal stents, they still can fail, they can plug, they can kill patients if they become occluded, and these patients need to be on nearly lifelong nebulized therapy with mucomist or hypertonic saline to prevent occlusion because they have no normal mucociliary clearance. And I don't need to remind you, it's like selling coal to Newcastle, that metal stents in the airway are just heresy, should not use them. And I think at the bottom, this is what the FDA says, that you should select patients carefully. I would argue you should not select any patients for using metal stents in the airway, because we spend a lot of our time taking patients who are referred from other centers who've had metal stents put in the airway and trying to peel them out, and this can be a horrific process. In terms of malignant airways disease, very, very common because lung cancer is a common disease and it's the most common cause of malignant airways obstruction. A typical patient that we see in our interventional pulmonary program is a patient who's been a non-surgical candidate up front. So this patient was stage 3B non-small cell lung cancer and hemoptysis, treated with carbotaxol and radiation therapy, had a moderate response, but presented with hemoptysis, focal wheezing, and dyspnea, and had this CT scan. And so when we approach patients with malignant airways obstruction, again, I have an approach which I have personally and which I hope to teach to my fellows, which is that intervention for malignant airways obstruction should be rapid. So as opposed to applying a little bit of electrocautery repeatedly over multiple bronchoscopies, my goal is to do a single procedure, palliate the patient, and get them home. That procedure should have low associated morbidity and mortality. It should require minimal follow-up because these are patients who may have a relatively short lifespan. I want them home enjoying time with their families. And it should maximize their quality of life. When I think about malignant airways obstruction, for me, I think about whether they have an intrinsic process and an extrinsic process, or both. This patient is not going to be a great candidate for laser photoresection. This patient may not need a stent, and so it's very important for me to delineate between the two so I can plan the procedure. Intrinsic processes you can manage with flexible bronchoscopy here. This is a flexible bronchoscopic electrocautery snare removal of a left main stem lesion, but at Penn, we manage almost all of these patients with rigid bronchoscopy. And I think it's important to, if you can click on the right-hand slide, that rigid bronchoscopy for pulmonologists is extremely rare. There was a survey conducted about 12 years ago that suggested that 4% of US pulmonologists routinely perform rigid bronchoscopy. I would posit that this is actually much less than that. There may be 100 to 125 well-trained pulmonologists in the United States who do rigid bronchoscopy, but there are so many advantages of doing rigid bronchoscopy for malignant airways obstruction that I think it's a prerequisite if you're going to embark on managing these patients. In addition to having the rigid bronchoscope for managing the airway, providing oxygenation, providing ventilation, coring out tumor, placing the stents, there are a number of other devices that we can use for thermal delivery or non-thermal delivery of energy to treat malignant airways obstruction, none of which has been proven to be better than the others. So electrocautery, APC, laser, we use them all. Laser was the device, if you can click on here, that we used most commonly when I first started. It's absorbed by tumor and vasculature. It's an excellent ablative technique for an endoluminal lesion. You can do it with conscious sedation or general anesthesia. But it's not superior, for example, to electric cautery in terms of ultimate outcomes. And electric cautery, actually, I don't know if this video is going to come up or not that important, but the bottom line is actually it's a very cost-effective way of treating endoluminal lesions. And if I advise people in third world countries who are starting programs in interventional bronchoscopy, this is actually a reasonable way to start if you want to, because all the devices that you might use are reusable, and it's very difficult to harm someone with electric cautery probe through a bronchoscope. In terms of stents for central airways obstruction, we use one of these two. This is the hybrid stent, and this is the Dumont stent. In malignant obstruction, there's less of a delineation between the benefits between silicone stent and between metallic stents, although metallic stents should be covered in malignant disease. The indications for airway stents in malignant disease include extrinsic compression, resulting in obstruction of the airway, intrinsic obstruction, which is present even after debulking with a rigid scope, and the presence of airway fistulae. This is what the airways look like after we've placed stents, a variety of them. Again, we typically use the hybrid stent or our Y stents or straight tube stents in these patients. If you're going to use metallic stents, there are some advantages, which is that you can place them under conscious sedation with flexible bronchoscopy. They don't really migrate, and in theory, there may be some improved clearance of secretions, but many downsides. They're incredibly expensive, they're difficult to remove, and they form granulation tissue, which will lead to multiple further procedures. So the ideal airway stent, if you were a pulmonologist, would be inserted through a flexible scope. It would establish a maximal airway lumen. It would allow regrowth of ciliated epithelium. It would be easily recaptured and removed. It would protect the patient from tumor ingrowth. It would have a low risk of obstruction of distal orifices, and in theory would be biodegradable and maybe drug delivery. This stent does not exist, but there are stents like this which are in development. So this is a paper from Laryngoscope from 2 years ago, which shows a biodegradable stent for the proximal airway, which actually elutes mitomycin C. So it has the characteristics of stent to maintain airway patency. It's biodegradable over a period of several weeks to months, and actually can elute any drug that you wanted. And what they showed was that the patients who had, these were done in animals, the animals that had the drug-eluting biodegradable stent actually did better in terms of stenosis than the stents that were not biodegradable or the stent that did not elute mitomycin C. So there may be stents in the future which will fit that ideal stent category, but they don't exist currently. There is very little data looking at survivals of different interventions. And I found this one paper relatively recently from 2 years ago, which looks at malignant airway obstruction in different scenarios: esophageal cancer involving the airway, lung cancer, and metastatic disease to the chest. And so if you've got esophageal cancer invading your airway or metastatic cancer to the airway, your survival is much worse with any intervention, stents, lasers, etc., than if you have a primary lung cancer. That being said, none of the survivals were very good. And it appears that if you just needed endoluminal therapy alone, in this case with laser, versus needing stenting or both, that your survivals were worse. Again, this is a single center from Switzerland, but there isn't a lot of multi-center data in this area. So in terms of a central airway obstruction algorithm, this is one we published 12 years ago in the New England Journal. And at this point, I was looking at whether or not this was an acute versus subacute process. If you had an acute process, you wanted to open the airway immediately with rigid bronchoscopic debulking. If there's extrinsic compression, you wanted to get a stent in the airway. If the patients were subacute, you had time to do some of the more delayed interventions that might work but wouldn't work immediately. Airway brachytherapy, which we do very seldom anymore, electrocautery, cryotherapy, PDT. These are not for emergent patients. But this is an algorithm that I found that I actually like a little better, especially for this audience, and I think it bodes well for how I'm going to manage patients going forward, which is that if you have a central airway obstruction, yes, decide if it's an emergent or a non-emergent process. If it's not emergent, ask the question as a pulmonologist, is this a patient who got a curative resection? If I've got a patient who's got a right main stem obstruction, but otherwise they're resectable, maybe what they need is a sleeve resection or a pneumonectomy and not me going in with a rigid bronchoscope. So I always ask myself that question, are they curable? And if they are, get them to John. He likes those big cases. If they're not curable, then I think about whether or not they're emergent or non-emergent, and then decide based upon whether or not they've got intrinsic or extrinsic disease, how I'm going to manage them bronchoscopically. So that's how I approach them right now from a pulmonologist trained by thoracic surgery perspective, and I'd be glad to take your questions. Thank you very much.